Hello everyone, I'm Dr. Sanjana, postgraduate student in the field of prosthodontics and crown and bridge, and today I will be covering a very important topic as a postgraduate and as well as a prosthodontist, that is face bow and its transfer. So let's begin. These are the contents of my today's presentation. So these I will be covering these headings. Under this I will be covering today's presentation. So just let's begin with introduction. Now, phasebow transfer is used in prosthetic dentistry to record the anterior-posterior and mediolateral relationships of maxillary occlusal cusp in relation to the transverse opening and closing of the patient's mandible. Now, the purpose of this phasebow is to transfer both aesthetics and the functional components from the patients to the articulate in a very efficient manner. So, now what purpose do phasebow have? That it takes the functional and aesthetic components of patients into considerations and transfer it to the articulator in a very efficient manner. So how we record and transfer it to the articulator, I'll explain in the further slides. So now let's see the definition of phasebow by GPT-9. It's defined as an instrument used to record the spatial relationship of maxillary arch to some anatomic reference point or points. So what are these reference point? We have anterior and posterior reference points, and I will be explaining it. What are those points? And then transfer this relationship and to an articulator. It orients the dental cusp in the same relationship to the opening axis of the articulator. Customarily, the anatomic reference points are the mandibular transverse horizontal axis on one another selected anterior reference point. According to Boucher, it is defined as the phasebow is a caliper-like device that is used to record the relationship of the jaws to the temporomandibular joints or the opening axis of the jaws and orient the cusp in the same relation to the opening axis of the articular. Now, according to Hartwell, phasebow is a caliper-like device to use to record the spatial relation of maxilla to the temporomandibular joint. Now coming to the classification of phasebow. Now classification is that phasebow is broadly classified under two, that is arbitrary and kinematic, where arbitrary are further divided as fascia type and earpiece type. So now let's see what is an arbitrary phasebow and its type. Now arbitrary phasebow approximately located the hinge axis. Now it is most commonly used for the complete denture. Rather than kinematic, we go for an arbitrary phasebow, and this type of phasebow generally locate the true hinge axis within a range of 5 mm. Okay, it approximates the points on the face of the posterior points and the condylar rods. It's further classified as fascia and earpiece type. Now, these arbitrary phasebows transfer arbitrary. They do not have a precise points or marks which is to be taken. They have reference point but not a scientific precise points. So now, what is a fascia type of phasebow? Now, these type of phasebow utilize the points over the skin and the TMJ as the posterior reference point. While using the fascia phasebow, the center of the condyle is arbitrarily located on the side of face 11 to 13 mm anterior to the tragus. Means that if this is the condyle, so it is anterior 11 to 13 mm. Okay. Now earpiece type. Now nowadays in this our clinics and the postgraduates use earpiece type of phasebow. In this phasebow, they use the external auditory meatus. Now, these external auditory meatus are these holes of the ear where we place our stethoscope. It is the same as like of a stethoscope. Now, it is an accurate as other phasebows and provides the average anatomic dimensions between the external auditory meatus and the horizontal axis of mandible. Now this is arbitrary phasebow. Okay, so we have seen arbitrary phasebow of ear type and a fascia type. Now we'll see the kinematic phasebow. Now this kinematic phasebow allows for the precise determinations of the patient hinge axis. Now what is a hinge axis? It is an imaginary line, okay, passing through the two mandibular condyles around which the mandible rotates without any translatory movement. So kinematic phasebow have a precise determination, not like an arbitrary phasebow where they have a reference point. So we have seen the classifications, which is kinematic and arbitrary phasebow. Now let's see the parts of phasebow. So here we have parts, that is a U-shaped frames, condylar rods, bite fork, locking device, and a third reference point marker. So now here this is a U-shaped frame. Okay, this is the condylar rods, this is the orbital pointer, this is the bite fork in which the occlusal rim has been attached, and this is the locking device. Now let's see individually each. Now this is a U-shaped frame and this is the orbital pointer, this is the screw where the locking device will attached. Okay, now this is U-frame is the main frame of the face bow. All the components are attached to this frame and it extends from the region of TMJ on one side and connecting the another face. Now two TMJ points connecting the face. Now bite fork. Now this is a U-shaped plate which is attached to the occlusal rim. Now this bite fork is for the edentulous patient, not for the dentulous. Dentulous patients we have another bite fork. Okay. Now this rod or the stem help us while joining the U-shaped frame with the locking device and frame. This bite fork should be placed 2 to 3 mm occlusal to the rims, which has been fabricated, and it should be done after taking a tentative vertical jaw relation. Now this is the locking device. Now this part of face will fix the bite fork to the U-shaped frame after recording the orientation relation. It also supports the face bow, occlusal rim and the cast during articulations. So here we can see we have two thumb screws, that is 1, 2 and 3, and in sequence only they should be tightened after taking a tentative relation. Once we are seen all the reference points and we have seen that everything is accurate, and after that only we should go for the locking of the devices. Now then we have a condylar earpiece. So now this is a condylar earpiece which is in front of the condyles and not in the external auditory meatus. So this is a fascia type and earpiece which goes inside the external auditory meatus. Now this is the orbital pointer. I have shown this in the U-shaped frame. This is the third reference position of the infraorbital notch. Now infraorbital notch is what? We'll palpate this infraorbital and we'll go a little down, and here somewhere comes the orbital pin, that is the third reference point. So now what we have seen from starting only, there is a reference point. What are the reference points? So now let's see the reference points. We have anterior and posterior reference points. So firstly we'll see Beck identified the baryon point as the next most accurate posterior point of reference. Now it is 13 mm anterior to the posterior margin of the tragus of the ear. So my ear, now this is the tragus. Okay, now this is the tragus of the ear. So this is the 13 mm baryon points to the corner of the eye. So this is the corner of the eye, and to this point which is 13 mm in front of the tragus of the ear. So this line is baryon point. Okay. Now Bergstrom point. Now 10 mm anterior to the center of the spherical insert on the external auditory meatus and 7 mm below the Franken's horizontal plane. Now Franken's horizontal plane is the lowest part of the infraorbital notch to the superior part of the tragus. So now these 7 mm below to this point and 10 mm anterior is a Bergstrom point. Now this point is the most frequently found in the hinge axis, and after baryon it's the most important posterior reference point. Now Geissy point. Now the Geissy point is where it is 13 mm in front of the upper part of external auditory meatus, okay, through the canthus of the eye. So here we can see that it is the external auditory meatus. It is above this point, okay, we can see, and this is Geissy point. So now for the posterior reference points, these are the three main important, that is Bergstrom point, Geissy point and baryon points, and for all the three the main common was this corner of the eye. Now let's see the anterior reference point. Now anterior reference points, we have a orbital. Now orbital is the lowest point of the infraorbital rim of the skull, which can palpate it on the patients through the overlying skin. One orbital and two posterior points determine the horizontal axis of rotation, while they find the axis orbital plane. Now second is orbital minus, now which represents the Franken's horizontal plane. 7 mm below the Franken's horizontal plane was a Bergstrom point, and orbital minus is Franken's horizontal plane. Now nasion minus 23 mm. Now this point is nasion It is the deepest part of the midline of the depression below the level of eyebrows. Okay, so here this is nasion. So now the nasion guides the face bow into the depression designed to be used with the articulator. Now U-shaped frame is located 23 mm below. It comes 23 mm below the midpoint of the nasion pointer. When the face bow is positioned anteriorly by the nasion guides, the frame will be seen in the approximate region of orbital. So we have seen orbital minus, nasion minus 23 mm, and the last is ala of the nose. So we all know ala of the nose, we know the camphor line and ala tragus line. So now this relationship can be achieved as a line from the ala of the nose to the center of the auditory meatus that describes the camphor's line. We all know and we have all done in undergraduate also, well, because taking of the jaw relation. Jaw relation cannot be completed by marking this ala tragus line and camphor's line. The desired location of the maxillary incisal edge should be marked on the back occlusal rim as an initial step to determine of the occlusal plane. Now this actually assures that the tentative occlusal plane will not be too high or low. So now with this we have seen the reference point, that is anterior reference point and posterior reference point. So anterior reference points we have orbital minus, nasion minus 23 mm, and ala of the nose. So now while we record and transfer, so these anterior reference point has to be taken into consideration as well as the posterior reference points. Now what are the posterior reference points? Posterior reference points, what we have studied is Bergstrom, Baryon points and Geisy point. So with this right till now we have seen classifications, definitions, part of face bow and the reference points. So reference points are very important. Now coming towards the significance of using a face bow. Now it aids in antero-posterior positioning of the cast in relation to the condyles. A correct horizontal plane is established. A face bow transfer record is an integral part in analyzing and studying the occlusal of the natural teeth. Therefore, the incisal plane is also properly established and finally in the vertical position of the cast in articulators. Now, advantages of face bow is that it aids in securing again the antero-posterior cast position in relations to the condyles of mandible, aids in vertical positioning, means it aids in both vertical and antero-posterior positioning, and aids in correctly transferring the inclinations of occlusal planes to the articulator. So now till now we have seen a theoretical aspect of what is face bow, what are the parts of face bow, what are the classifications, what are the reference points which has to be taken into consideration, and its advantages and significance. Now the next what we'll be seeing is face bow and its transfer. So now this step is very important as a prosthodontist and as a postgraduate student. This transfer is very important because we as a postgraduate has to do this step in a final year, that is a third year examination in the clinic. It is one of the major steps which has to be performed in the examination, that is face bow record and its transfer, and it is very important that it has to be accurate. So now how to do this we'll see in this video. So before that I have given a brief idea about what is a face bow, what parts do it has, and what reference points we have to see while we record the face bow. So now let's see, this is the video record of my own patient. So now firstly what has to be done, that we have to record tentative vertical relation in the patient, and let's see now this, that the midlines of both maxillary and mandibular rims are coinciding and we have a good occlusal contacts. This is the parts of face bow which has been already discussed. Now we'll assemble the bite fork. Now bite fork is assembled 2 to 3 mm above the occlusal plane, and this stem should be at right side of us. Okay, and after this line now we can see that is 2 to 3 mm, and we need to do seal after this. For seal we can use sticky wax, but I have used modeling wax as it gives homogeneous mix and a good look. After that, we have to place it into the patient's mouth with a good adequate head rest, and it should has a good retention, the record base and the rims. Once that is done, now we'll place the whole assembly. Also before that, we'll place the mandibular occlusal rim because it gives supports to the assembly and patient, and we'll ask the patient to close in centric. After that, the assembly will be transferred with the help of patient, or we can use forehand dentistry if the patient is not comfortable. After that, we'll use we'll insert the U-frame with the locking devices. The locking device will be attached to the stem of the bite fork, and make sure that all the thumb screws are loosened before we proceed for the procedure. Once that is done, we'll mark the third reference point, that is infraorbital notch. Ask the patients to close the mouth throughout the procedure so that we have an correct relation of the patient. Once that is done and you have checked all the anterior and posterior reference points, and it matched, as we can see that it is 23 mm below the nasion point, infraorbital notch is correct, then we'll tighten the screw. Now the tightening of the thumb screw has to be followed in the sequence I've already told, that is 1, 2 and 3. After checking the anterior and posterior reference points, we have to tighten the screw. This thumb screw has to be tightened before only because it stabilizes the whole assembly. Once you have verified again after tightening the screws that the reference points were correct, we'll remove the assembly with the help of the patient, and then comes the transfer. So now we will use Hanau articulator. This is the mounting jig. This is the Hanau articulator. We have this mountain jig is placed and patient, and here will place the assembly. So these points are for the earpiece, and we have placed the central rod with the mounting jig. We'll stabilize the maxillary rim with the help of mounting jig so that it has an adequate support throughout the transfer, and a transfer which we has been taken should not be disturbed while mounting the procedure. So once that is done, we'll check it that it is correct by the coinciding the orbital pin and the orbital pin of the articulator, as we can see in this video. And once that is done, we'll check that all the points correctly is being done, and after that we'll go for mounting. In this video the mounting is not been covered, but this is the complete video of Facebook record and transfer. So Facebook records anterior and posterior reference points are very important. So this was the video. So now by this video I have completed the Facebook, what is Facebook record and its transfer. So with this I'll like to conclude that many methods of assessing and recording jaw relations in edentulous patient has been presented and evaluated. But since there is no definitive method of recording the maxillomandibular relationship, therefore, in the absence of reliable method, clinical judgment of the dentist becomes a decisive factor. Now, recording the Facebook is an art rather than a science. Definitely it's a science, but moreover it is the art of the dentist, a prosthodontist. This is the reason why there are methods used, and one by one method is good as other. So, I hope this presentation was really helpful to you, where I have covered the theoretical aspect of Facebook and the video of Facebook and its transfer. This video would be really helpful to the new first year postgraduates, which is really just now enter to the colleges, and being a postgraduate, Facebook is very important, and we have many queries how to record, how to transfer. So this video, this presentation will be really helpful to you. But any presentation, any model does not complete without asking the questions. So now it's time for quiz. Simple questions to be asked to make sure that you are attentive throughout the presentation. So the first question is that what was the point 13 mm posterior margins of the tragus to the canthus? I hope it was really very easy. It was a posterior reference point, that was a baryons point. The second question comes that do Facebook attach the mandibular cast or to the maxillary cast to the articulator? Very easy. I hope of the first week postgraduate also can answer this. That is definitely the maxillary cast. Now the third question and the last one is identify this image. I hope even this is very easy. This is bite fork. This is edentulous bite fork, to be more specific. So these were the references for my this presentation, and I would really thank I appreciate and I give my sincere gratitude and to the Indian Prosthodontic Society 51st conference in Goa for giving this platform to postgraduates to showcase their learning and teaching skills to the students and the prosthodontics over here. I'm really thankful to you, and I also extend my gratitude to the Department of Prosthodontics, Crown and Bridge, for giving me this opportunity to come forward and present this wonderful topic, Facebook and its record. The video recording was purely done by me, and the identity of the patient was revealed in this video. So for that, a proper consent was taken from the patient. It was informed to the patient prior about the video shooting and using the video for this presentation. A proper consent was signed from the patient about this, and the patient was willing for the video shoot and the use of the video for the further presentation also. And I hope this presentation and the video was really helpful to all the budding prosthodontists, and thank you so much one and all.